Then she gave more information about the receptors.
Yes, yes. The interaction between, for example, T cells and antigen presenting cells and T cell receptor, the structure, yes, and also about the mechanism of autoimmunity, yeah, the pathogenesis of autoimmune disorders, and today we are going to talk about some autoimmune diseases. For example, about lupus, systemic lupus erythematosus, about Sjogren disease, and about scleroderma and systemic sclerosis. And after that, we are going to talk about the mechanism of transplant rejection and graft versus host disease. And we also talk about primary and acquired immunodeficiencies, and the most important one is AIDS. But about immunodeficiencies, we are going to talk about them tomorrow. Okay? And the last topic is amyloidosis. Okay? So today we are going to first we are going to talk about autoimmune diseases. And can you describe this picture for me? This is the mechanisms of autoimmune disorders. As you know, autoimmune disorders maybe, all of them have some mutations in genes. So a person with autoimmune disease has a genetic susceptibility. Yeah? Because of gene mutations, the patient has failure of self-tolerance. Do you remember what tolerance means? Tolerance, immune tolerance. It means when our lymphocytes, have receptors for an antigen, and there is interaction between these receptors and those antigens, the lymphocytes become responsive to that antigen. And there are different mechanisms of self-tolerance. So self-tolerance means that our body does not respond, our immune system does not respond to autoantigens, to our own antigens. So when we have an autoimmune disease, we have a genetic susceptibility, and we have failure of self-tolerance, and so we will have lymphocytes, either B lymphocytes or T lymphocytes, that are self-reacting, yes, and they act against our self-antigens, okay? And about all autoimmune diseases, we have some environmental triggers, for example, infections, or things that cause apoptosis of our cells. So we will have exposure of self-antigens, and those lymphocytes who are self-reactive, interact with those self-antigens, and we will have an immune response against those self-antigens. Okay, so we have genetic susceptibility and some environmental triggers, and we will have tissue injury due to the action of immune system against our self-antigens. About different kinds of autoimmune disorders, the genes and the environmental triggers are different. For example, about lupus, the environmental trigger is one of the important ones is UV. When a person who has SLE, his or her skin becomes some damage, the act of UV causes some kind of apoptosis, and we will have immune response, for example. And for example, about Sjogren's syndrome, some viral infections are the environmental cause. And the fact is that for many autoimmune diseases, the exact cause may be unknown. So maybe when you study the book, you will see that, for example, about scleroderma or systemic sclerosis, the cause is unknown, the environmental cause. Or maybe you can find it only in papers, not in textbook. Yeah? Because they are theoretical. Okay? So this is the mechanism of autoimmune disorders. And now about systemic lupus erythematosus. Have you ever heard about this disease, SLE? Yeah, you may have seen patients with SLE.
They have butterfly, I think.
Yes, they have butterfly rash, yes, exactly. And this is a common autoimmune disease. That's why we are going to talk about it first. Autoimmune disorders, some of them are organ-specific and some of them are systemic, yes. SLE, as you can understand from its name, is systemic. So it involves multiple organs, and in SLE we have antibodies that act against the components of nucleus, okay, and they are called anti-nuclear antibodies or ANA. Okay? And do you remember hypersensitivity reactions, type 1, 2, 3? In SLE, mostly we have type 3, and we have the position of immune complexes in vessels or other tissues, and sometimes we have type 2. We have autoantibodies that act against tissue antigens, okay? And prevalence is as high as 400 per 100,000 in some populations, and the typical patient of SLE is a young woman. Okay, so it is very common in a person in the 20s or 30s, and especially in women. But you should know that it can be seen in children and in elderly, and when it happens in patients between 17 to 55 years old, the female to male ratio is 9 to 1. But in children and elderly, it is 2 to 1. Okay, so it is always more common in women, but in childbearing age, it is much more common. Okay. Okay. Let's take a look at this table. Oh. think it's better for you to learn it now because you will have it in internal medicine or in rheumatology section. Okay? For diagnosis of SLE, we have some criteria. Okay? And they are categorized into clinical criteria and immunology criteria. And for establishing the diagnosis of SLE, we should have 4 of these criteria, and there should be at least 1 clinical and 1 immunology criteria. Now, what are the criteria? The clinical criteria, some of them are some symptoms. You know, the first 4 ones are symptoms that are related to skin and mucosa. What are the skin manifestations of lupus? One of them you told me.
Butterfly.
Yes, the butterfly rash, malar rash, and photosensitivity. The patients with SLE have photosensitivity and they should avoid sun. Okay? And you see the picture of malar rash or butterfly rash. Okay? The rash exacerbates when the patient is under sun. Okay? And the other one is chronic lupus, chronic cutaneous lupus. It is in the form of a discoid rash. It is an patch which is erythematous and raised, and it has protein scaling and follicular globin. You see it in this picture. A discoid rash. It is a raised erythematous rash and it has scales on it. Okay? So, the first 2 ones were related to skin, acute cutaneous lupus, butterfly rash, photosensitivity, and chronic cutaneous discoid rash. Okay? And the third one is a kind of alopecia, non-scarring alopecia. What is alopecia?
Loss of hair, patches.
Yes, exactly. Loss of hair. You see it in this picture. It is a kind of alopecia that occurs in patients with SLE. And the other one is ulcers in oral or nasal mucosa. The patients may have ulceration in oral or nasopharyngeal mucosa, and the ulcer is usually painless, in contrast to office ulcers, which are usually painful. These ulcers are painless. You see it here. It may be in oral mucosa or nasal mucosa. And so, the first 4 ones were related to skin, hair, and mucosa. Yes? And the other one is joint disease. These patients have arthritis. Okay? And the arthritis is non-erosive and it doesn't cause deformity. In some disorders such as RA, rheumatoid arthritis, we have deformity of the joints, but in SLE we do not have deformity. We have non-erosive synovitis, and it involves peripheral joints, and it doesn't lead to deformity of the joints. And we also have serositis, different serosal surfaces. For example, precardium, pleura, okay? They may become inflamed, and we will even have effusions of precardium or pleura, precardial effusion, pleural effusion. Yeah? And one of the most important and common things that we see in SLE are renal disorders. And you may have proteinuria or artistic casts in the urine, and this is an important criteria. We may have also neurologic disorders, for example, seizures, psychosis, myelitis, neuropathy, and these can be criteria for
blood, something like
complete blood, yes, complete blood count. So we may see hemolytic anemia or leukopenia or lymphopenia and thrombocytopenia in patients with SLE. Okay, so skin, hair, mucosa, joint, cellular surfaces, renal disorders we may see, neurologic disorders, and
Blood
we may
disorders.
see anemia, leukopenia, and thrombocytopenia. These were the clinical criteria. And we also have some immunologic criteria, antibodies and things like that. I told you that in SLE we have antinuclear antibodies. Okay, so we may have INR or ANA, which is a general antinuclear antibody, or more specific type, such as anti-galvestron DNA, anti-SE antibody, and we may also have antiphospholipid antibody. I think you know about antiphospholipid antibody syndrome. Yeah, you had it in hemodynamic disorders. It causes thrombosis and miscarriages, and we have different types of antiphospholipid antibodies. For example, anticardiolipin antibody, lupus anticoagulant antibody, or for example, sometimes it causes false positive syphilis test, and all of them can be criteria of lupus. I think in hemodynamic disorders you learn about antiphospholipid antibody. Yeah? Did you? No? No? We have some kind of disorders in which we have antibody against phospholipids and proteins. Okay, and they cause widespread thrombosis in veins, arteries, and it will cause, for example, ischemia in brain or eyes or other parts of the body. Okay, and they may also cause, miscarriages, in pregnancy, early abortions. Okay, and sometimes we have primary antiphospholipid antibody syndrome, and sometimes it is secondary and associated with lupus. Okay, so antiphospholipid antibody can be seen in lupus and it's a criteria. And I told you that in lupus we have type 3 hypersensitivity, which means we have deposition of immune complexes. Yes. So we have consumption of complements and we have low complement count in blood, low C3, C4 or CH50. And again I told you that we have hemolytic anemia in SLE. So we will have direct Crohn's test. I mean we have anti-RBC antibody. Okay? So you should be familiar with these criteria. Because this is pathology and we are going to focus on pathogenesis and morphology, there will be no questions. For example, I tell you a patient has, for example, this skin manifestation, this, for example, renal manifestation, and etc. And I tell you whether she has or he has lupus or not. But you should know the criteria, okay? Especially the laboratory criteria, you should be familiar with them because in pathology, laboratory data are important, okay? Is it okay?
Yes.
Okay, malar rash, discoid lupus, alopecia. Again, here you see the alopecia. And of course, in lupus, we also have scarring alopecia, non-scarring and scarring, both of them, and mucosal ulcers. Okay, I told you that we have different kinds of antibodies in lupus. Okay, and I told you that the most important ones are positive. It's a general antinuclear antibody, but sometimes you have to specify it is against, for example, histone, for example, double-stranded DNA, single-stranded DNA, or for example, non-histone proteins, okay? So the patients with lupus and many patients with other kinds of autoimmune disorders have positive ion, okay? But now we are going to talk about more specific ions, okay? They may be against DNA, histone, non-histone proteins that are bound to RNA, nucleolar antigens, and in order to study the anti-nuclear antibodies, we use a method, a laboratory method, which is called indirect immunofluorescence. Have you ever heard about indirect immunofluorescence? As you can understand from its name that it's a method that we use fluorescence to see something. We use fluorescent material and fluorescent microscopy. And I will gonna talk about this method first. What do you see in this picture?
The nucleus.
The structure of nucleus. You have nucleus here, and here you see that you have chromosomes, centromere, and here you see histones, what are histones? Can you tell me what histones are? Protein backbone of DNA, yeah.
It wraps around it.
Yes, exactly, as you see in this picture. You can see antibodies against all of these parts: anti-centromere, anti-histone, anti-DNA, and things like this. Take a look at this picture. This is how indirect immunofluorescence study works. In indirect immunofluorescence study, what you examine is patient's serum. Okay. A patient is suspicious of SLE. Okay, and I think in his or her serum there are anti-nuclear antibodies. Okay, and I want to test the patient's serum. Okay, so I should have the antigen and test the patient's serum in order to see if there is antibody against that antigen. So in the lab, I have the antigen here. Okay, and here I have the patient's serum, and I use an antibody which is marked by fluorescent material in order to find out if there is antibody against that antigen in the patient's serum. So I use an antibody which is labeled by fluorescent against the patient's antibody. Okay? And I will examine the specimen with a fluorescent microscope. So if there is antibody, I will see positive fluorescence. Okay? And if not, I will see negative result, no fluorescence. Is it okay? 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 Okay or okay? Okay? Okay, I will show you the pictures. For example, here, I have the nucleus here, okay, and I have used the patient's antibody serum and antibody which is labeled by fluorescence. And I have different patterns of staining of cells, okay. For example, here I have homogeneous or diffuse staining pattern. You see homogeneous staining of nucleus, yes? And it means that there are antibodies against chromatin antibodies against double-stranded DNA or nuclear envelope proteins. Here I have centromeric pattern. Antibodies against centromere. It means that most of the time it is seen in systemic sclerosis. Here, for example, I have a speckle pattern. You see fine speckle. It is categorized into fine speckles and coarse speckles, and it means, for example, this is not specific, and it may be seen in antibodies to, for example, SM antigens or ribonucleoproteins, SSR, SSB, and here you see nucleolar pattern, and it is seen in systemic sclerosis, nucleolar pattern. What I want you to know is the mechanism of indirect immunofluorescence and the more important patterns. For example, centromeric pattern is important. Okay? Or for example, only centromere, because it's so typical. The centromere pattern is so typical. Okay? So it is important to know the centromere pattern, and it is important to know that it is seen in systemic sclerosis. Okay? And here again you see the patterns. For example, ring pattern, homogeneous pattern, speckle, and centromeric and nucleolar pattern. I don't want you to know the details, for example, these details or these details. I think later you have to learn them. But now I want you to know the mechanism of immunofluorescence and indirect immunofluorescence and the more important patterns. Okay, and apart from antinuclear antibodies, we have other types of antibodies in lupus. For example, we have antibodies against RBCs, platelets, and lymphocytes. I told you we have anemia, hemolytic anemia, lymphopenia, and thrombocytopenia in lupus. And we also have antiphospholipid antibodies in 30 to 40% of patients with lupus. And we talked about it. We may have positive, syphilis case, or we have lupus anticoagulant, and these are the things that we see in antiphospholipid antibody syndrome, which is secondary to SLE. Okay, do you want any rest or 2 minutes rest? Did you understand?
Yes.
Yes. Is it okay?
Yeah.
These are mostly, for example, the typical patient of SLE is a young woman. Okay? And about the criteria, for example, the last 3 clinical criteria, anemia, leukopenia, thrombocytopenia.
The blood diseases.
Immunologic criteria, all of them are important, because
Pathology.
pathology laboratory data are important. The clinical data are not that important except the last 3 ones. And about the autoantibodies, the most important thing in lupus is that you know that you have
ANA,
general
anti-Q.
ANA and anti-double-strand DNA and anti-SNP antibody. Okay, and also I think it's not that important, but you should know that. For example, for the exams, I think you have exam, comprehensive exam. You have is
Pathology, no, it's not good.
And about antiphospholipid antibodies, you should know them. It's important. You should know that we have primary antiphospholipid antibody syndrome and secondary. Secondary is most of the times associated with SLE, and you should know that we have false positive test for syphilis, and we may have lupus anticoagulant antibody the cause or causes are uncommon. And like most of the autoimmune disorders, we have some genetic, causes, at least hypothetically, and environmental factors that are, affected in the study. For example, about genetic factors, it has been seen that there is some familial association in ST. For example, if a patient has a family history, it is more probable that he or she gets this disease.
So
And
it's autosomal or
no, that is not, it's not Mendelian.
it's not Mendelian.
No, the inheritance is not Mendelian. It is all, only the exact genes are not fully understood, and all of these are theories, and they are not true about all patients. For example, in some patients, familial association has been seen, in some not. In some patients, HLA association has been seen, HLA DR2 or DR3. And for example, other genes also have been seen. For example, deficiency of some complement factors.
Classical
The classical pathway C1q, C2, or C4. But this is not true about all patients. Okay? In some patients, for example, in a group, HLA association, but relative risk is low, and in some, in Mendelian disorders, if you have the gene, most of the times, if a person has a gene, he or she will have the disease, except, for example, what we see in, some, exceptions. There are some exceptions, but this is not the mode of inheritance in aesthetic. And about the environmental factors, you see, as I told you, UV light is important. But why does UV light induce immunologic, tolerance to glass? There are some theories. For example, it is said that UV light induces apoptosis and it alters the DNA and makes the DNA immunogenic. And DNA is recognized by toll-like receptors, and you will have inflammation. Or it is said that UV light may cause the plasmacytes to produce interleukin-1 and induce inflammation. Okay? And other environmental factors are, for example, gender. SLE is more common in
Women.
women, and it may be because of some genes which are located on X chromosome or some hormones, and they are also kind of environmental factors. Or it is interesting to say that drugs can cause SLE-like disorder. Okay, drugs such as hydralazine or propiramide or dipenicillamine, these are the drugs that reaction against self-antigen. You should know that both humoral immunity and cellular immunity are impaired, and also we have some, abnormality in cytokines. For example, we have B cell, failure of self-tolerance, and it can be central or peripheral. We have CD4 positive helper cell, defect, and we may also have a large amount of type 1 interferon. Sometimes we have, some signals from toll-like receptors that activate some B cells that are specific for self-nuclear antigens, and sometimes, for example, some special kinds of TNF, for example, BAF, are affected. In this picture, you see, how, immunologic factors, immunologic intolerance occurs. Here you see what
Apoptosis.
These are, okay, let me show you. I told you that in all autoimmune disorders we have genetic susceptibility and environmental factors. Because of genetic susceptibility, we have B and T cells which are specific for our cell nuclear antigens, and we have some environmental factors, for example, UV radiation, which causes apoptosis, and we have high amount of nuclear antigens in body. And so we have nuclear antigens and B and T cells that are specific for these antigens. So we will have antigen-antibody complexes. These complexes start to deposit in different tissues, in kidney, in, for example, vessels, in the skin, and other tissues. And we also have, for example, here you see we have ingestion of these complexes by, for example, dendritic cell, and the dendritic cell secretes type 1 interferon, and it stimulates B cells, and we will have more B cell stimulation and plasma cells that secrete antibodies, and we will have high level of stimulation of immune system and production of antinuclear antibodies, and this makes the things even worse. Production of these complexes induces more mechanisms of self-immunity, and we will have a persistent high level antinuclear antibody production. Okay? So we have genetic susceptibility, environmental factors, antigen-antibody complexes, and type 3 hypersensitivity most of the times. But sometimes we have type 2. And because we have, the position of immune complexes, complement system is activated. So in our serum, we will have decreased amount of C3C4 and CH50, and it is very important in diagnosis of SLE. And we also, by examining, for example, kidney, we see the granular deposits of antibody and complement in, for example, glomeruli. Okay? And we also have, for example, antibody against RBC, YBC, and platelet, and this is type 2 hypersensitivity. What is the difference between type 2 and type 3? Type 3 is circulating immune complexes, but type 2
Fixed.
have antibody and, for example, the antigen is fixed. We have antibody against the antigen in the tissue. Okay. Sometimes, for example, in tissues we have nuclear damage. Okay, and these damaged from some amorphous hematoxylin material, okay? And we call them LE body. In the past, we used this test, LE test for diagnosis of SLE. We looked for these LE bodies in blood. This is, this is a neutrophil. This is a neutrophil, and this is the nucleus of neutrophil, and inside the neutrophil we have LE body. But nowadays we have INR or antiglobulins from DNA, and we do not need LE test anymore. And in histology, HNA stain, we also may see LE body. Here it's a glomerulus, and you see LE body here. So the act of antibody against damaged nucleus cause hematoxylinic amorphous round material, which is called LE body. Okay, and I told you that we have antiphospholipid antibody syndrome in lupus, which is because of, for example, some antibodies against phospholipids and proteins, and that causes spontaneous miscarriages and cerebral or ocular ischemia and widespread thrombosis, which may be seen in veins and arteries. Okay? And also in lupus, we have some neuropsychiatric manifestations. For example, what do we see? For example, as I told you, we may see seizures, yeah, neuropathy, myelitis, yeah, we may see psychosis, okay? And that is because some antibodies cross the blood-brain barrier, and they react with, for example, neurons or receptors of neurotransmitters, and sometimes that is because of the act of cytokines. We do not have vasculitis in brain. In other organs, we mostly have vasculitis, but in brain, most of the times we have vascular occlusion, but no inflammation. Okay, morphological changes are important. For example, in blood vessels, you may remember from the chapter cell engineering, the type of necrosis that is the result of immune complex deposition in vessels walls is called fibrinoid necrosis. Yeah?
Yes.
We had fibrinoid necrosis, for example, coagulative and things like that. Here we see fibrinoid necrosis. This is a vessel. This is the lumen of the vessel. We see RBCs inside it. You see here a vessel, yeah? A vessel, this is the lumen, yeah? And we have, thickening of vessel wall, yeah? And here you see the position of this eosinophilic material, fibrinoid material here, and this is fibrinoid necrosis of the vessel wall, which is caused by the position of immune complexes. And in kidney, kidney involvement is very important in SLE. Up to 50% of SLE patients have clinically significant renal involvement, but I told you, 50% clinically significant renal involvement, but the kidney virtually always shows evidence of abnormality if examined by electron microscopy or immunofluorescence. It means that we have the position of immune complexes there, but still we do not have something that we can see by light microscopy, and we do not have symptoms yet. Okay, so always we Okay, so diffuse lupus nephritis is the most common type of nephritis in lupus. Here you can see the structure of a glomerulus. What are these
Lumens, capillary.
capillary lumens? Yeah. And here you see the endothelium. Yeah. And you have two types of epithelial cells. You have
Podocyte.
histaya, podocyte with food processes, and you have this parietal epithelial cell. Okay, lines the Bowman capsule. And here you have what? Here, mesengium, and you have mesengial cells and mesengial matrix, which is the supporting tissue for the glomeruli. And again here you see the lumen of capillary endothelial cell, which is fenestrated. Yeah. And here you have basement membrane, and here you have the podocyte. We call it now epithelial cell. Okay, epithelial cell, basement membrane, and endothelial cell. And here we have mesengium. And again here it's a bit difficult when it comes to H&E stains. Of course, I think it's PAS stain because the membranes are actually accentuated. But here you see, for example, it's a capillary lumen. Here you see basement membrane. Yeah. And here you see the endothelium. And here you see endothelial cell. Okay. And for example, you see the podocytes here, epithelial cells here. And here you have the parietal epithelial cell, here you have podocytes. And this is the Bowman capsule around it. And among that, you see mesangial cells. It's a bit difficult to differentiate different types of cells here. Yeah? For example, epithelial, endothelial, and mesangial cells. It's difficult. So, in practice, we use different histochemical stains in kidney biopsies. For example, we use PAS stain, silver stain, we use immunofluorescent and electron microscopy. Okay. If a pathological process involves all glomeruli in kidney, we call it diffuse. And if not, we call it focal. And in one glomerulus, if the process involves the whole glomerulus, we call it global. And if part of glomerulus, we call it segmental. So you should know the difference between diffuse and focal, and global and segmental. So you will have, for example, focal segmental glomerulosclerosis. It means that it doesn't involve all the glomeruli, and in one glomerulus, and the segment of it is involved. Okay, again, here you see this structure. You see, for example, here, endothelial cell, membrane, and epithelial cell. So, if I tell you that a deposition is subepithelial, I mean it's here. Okay? It's here. And subendothelial is here. Okay? And when I say the membrane is involved, I mean this membrane. Okay? So in different types and classes of lupus nephritis, we have different types of involvement. For example, the class 1, minimal mesangial lupus nephritis. We have deposition of immune complex in mesangium. And we don't see deposition of immune complexes in mesenterium. The mesangial cells are proliferated, and we also have accumulation of mesangial matrix, and we have deposition of Ig and complement in mesenterium. But still, glomerular capillaries are not involved. So, this is my formal lupus nephritis. But in class 3 and 4, we have involvement of glomeruli. The difference is that class 3 is focal, and less than 50% of glomeruli are involved, okay? But class 4 is diffuse. So, in class 3 and 4, we have, for example, swelling and proliferation of endothelial and mesangial cells, we have inflammation, we have neutrophils, we have necrosis of capillaries, thrombi in vessels, and we will have symptoms, okay? The patient will have hematuria, blood in urine, and proteinuria, okay? He or she may have renal insufficiency, okay, high creatinine level, and maybe RBC cast in urine and things like that. Okay, so we will have involvement of glomeruli and mesangium. Okay, both of them, and we will have proliferation. Okay, proliferation of what? Endothelial cells, mesangial cells. We have inflammation, we have necrosis, we have thrombus. Okay, and here is what we see in, for example, class 2. Now you cannot differentiate class 3 and 4 easily only by examining one glomerulus, because you should have some glomeruli to examine if all of them are involved or just less than 50% of them. Here you see that you have proliferation of endothelial cells, and here you see neutrophils. It's not important now to for you to diagnose based on histological images, because you will have it in I think next term, next semester in keeping pathology. I think you just know the mechanisms. But here again you see proliferation and neutrophilic accumulation, and here again you see necrosis. Here you see necrosis, which is focally seen in glomerulus. Okay, and diffuse lupus nephritis for class 4, we have diffuse involvement, more than 50% of glomeruli. And again you will see, for example, proliferation, and you will see mesangial expansion, or sometimes you will see crescent formation, something like crescent. You will see glomeruli, that is the cause of proliferation of, for example, epithelial cells, and crescent formation means that you have severe involvement of glomeruli. And again, here you see this, and here again you see this deposition here, and in immunofluorescent study you see glomerular deposition of immune complexes. Okay? About type 4, type 5. Type 5 is, the thing that you see is thickening of capillary basement membrane mostly. And you see, the thing that you see in this type is proteinuria. It's like nephrotic syndrome. Okay? In nephrotic syndrome, you mostly see proteinuria. Yeah? And here in type 5, you see proteinuria and nephrotic syndrome, and what you see is thickening of capillary walls. Okay? Here you see thickening of the walls of capillaries, but you don't see proliferation of endothelium or epithelium organization. Okay? You see only thickening. And in advanced sclerosis, you see sclerosis, fibrosis. The result of all chronic inflammations is fibrosis, yes, and sclerosis. And if you have a sclerosis of more than 90% of human life, does the kidney work? No. Do we have?
Kidney failure.
Yes, end-stage renal disease, ESRD, and that's the last thing that happens. Okay, about skin manifestations of lupus. I told you that we may have butterfly rash. What do we see microscopically in a patient with butterfly rash? Again, like what we see in other organs, here again we see the position of immune complexes. Here you have epidermis and here you have dermis. And this is the basement membrane. Okay? You have linear deposition of IgM complement in basement membrane. Okay? And by deposition of immune complex, you have some kind of destruction of cells. Okay? Here you see, here are the keratinocytes. You see apoptosis and destruction of basal keratinocytes mostly. Here you see vascular damage of keratinocytes. So, in butterfly rash, what you see is, in skin is death of keratinocyte due to immune complex deposition. And again, because in dermis we have vessels, okay? We have vasculitis of dermal vessels. And in other organs, for example, in joints, we have arthritis and we have central nervous system manifestations, as I told you. And I told you that most of the time we do not have vasculitis in CNS. We have non-inflammatory occlusion of the small vessels. And in, I told you, kidney is the most important organ involved in lupus. Yeah? Another important organ is heart. Okay? In all the layers of heart, we may see involvement. Okay? For example, in pericardium, we may have effusion, inflammation, even tamponade, okay? And in myocardium, we have myocarditis. We may even have coronary artery disease, okay? And in the endocardium, we may have endocarditis, which is called lymphocyte endocarditis. It is characterized by the position of some, immune complexes in cardiac valves. Okay, lymphocyte endocarditis. Now it is not common because SLE is diagnosed soon, and corticosteroids or, for example, anti-immune medications are started for the patients. So now it is not so common. But in the past, lymphocyte endocarditis was common because there was no suitable medication for SLE. Okay, and we have two different, subtypes of lupus, which are milder. So we have systemic lupus erythematosus, and that is a systemic disease involving kidney, heart, and other 35 patients, 35% of patients, no, that's not, 5 to 10% of patients made progress to SLE after many years, okay? So, a few number made progress to SLE sometimes. But most of the times, there are no systemic manifestations, only cutaneous manifestations. The patients have some clots which are scaly. Most of the times, they are on the face and on the scalp, and they have, for example, edema, erythema, scaliness, follicular plugging, and sometimes skin atrophy. And some of them, 35% of them have positive ANA, but presence of anti-double strand DNA is very rare. Okay, and if you examine skin by immunofluorescence, you will see the position of Ig and complement in dermal junction, as I showed here, the same as this. This is called a lupus band. And it can be helpful in diagnosis of lupus. Sometimes we do it in the pathology lab. So DLE involves most of the times the skin, and progression to SLE is rare. And about subactive cutaneous lupus erythematosus, it is something between DNA and SLE. You have a skin rash and you have systemic symptoms, but they are mild. Okay? And it's interesting to know that there is a strong association with antibodies to SSA antigen. We will have it in Sjogren and HLA-DR3. SSA antigens or raw antigens are mostly seen in Sjogren disease, but they are also seen in lupus. And about drug-induced lupus